going down, personnel says designated individual other than the practitioner performing the procedure present to monitor the patient throughout the procedure, and this person may assist with minor interruptible tasks. For deep sedation, the monitoring individual may not assist with other tasks. Would you agree with that if you're running an infusion in a home setting?
Yeah, that's correct, but you'll note they refer to a procedure going on. That means someone is performing either a diagnostic or therapeutic procedure, and so they wouldn't be appropriate to be monitoring the patient.
So, but do you think if propofol was given in a home setting for not for a procedure, but to put someone to sleep, are you saying you don't think it's a good idea to have those precautions in place?
I don't think I said that, sir.
Okay, you would agree that it is a good idea to have those precautions?
What I'm just pointing out is they're referring to someone doing a procedure and suggesting there needs to be a second person there to monitor the use of an infusion for sedation, and I think that is a good practice, and I endorse that. But what I'm suggesting is it seems like you're making the analogy that that's the same as someone providing propofol for a different purpose.
Well, I just want your opinion. Do you think if someone's providing propofol for sleep in a home setting, that there should be, for example, another person present in addition to the medical doctor?
I think they certainly need appropriate monitoring if they're using an infusion. It's not a practice that I'm familiar with, nor have I heard of it being described in the past, so I can't really make a recommendation as to the need for a second person, assuming that the physician that is providing the sedation is qualified and is devoting their attention to the patient.
So you'd at least be assuming that the doctor administering the propofol, at least that one person is at least present and monitoring the patient, correct?
While the propofol is being administered, absolutely.
And then it goes through recommended training in pharmacology, is that right?
Yes, sir.
And going to the right column, it discusses both the need for basic and advanced cardiac life support skills.
Yes.
Runs through the various emergency equipment, including suction, drugs, a defibrillator for deep sedation, oxygen, choice of agents, induction agents, and goes through all the recommended various agents that would be appropriate in that type of environment where moderate or deep sedation was taking place, correct?
Correct.
And recovery, number 14, they identify the need to observe observation until patients no longer at risk for cardiorespiratory depression. Is that right?
Correct.
Now, do you think these guidelines are appropriate if someone's administering propofol in a bedroom of a private residence with no other staff present?
I think in general these describe very excellent recommendations for administering a propofol infusion in any environment.
What about administering benzodiazepines and a propofol bolus? Do you feel that these recommendations are appropriate?
Well, as I alluded to earlier, certainly benzodiazepines parenterally are administered in home environments by physicians and hospice caregivers and others without all these monitoring procedures.
I'm asking your opinion, Dr. White, if you think if someone's administering benzodiazepines and let's just say a bolus dose of 25 milligrams of propofol in a home setting with none of the, do you feel that the guidelines here would be appropriate if your concern was to put the patient first?
Well, I certainly would agree with putting the patient first in all situations and not putting them at any risk. What I was alluding to was that while these are the standard of practice, which is the gold standard, the highest possible standard in practice, I'm suggesting that certain situations in the home where these drugs are administered may not have all the specific monitoring guidelines that are mentioned here. Not that it would be a bad idea to have those. Certainly, again, you wouldn't want to compromise patient care.
So it'd be a good idea to have these recommendations in place if you're administering even bolus doses of propofol in a bedroom in a home setting.
In an ideal situation, absolutely right.
Your Honor, may I inquire if we have the defense exhibits out? Or?
Mrs. Benson? They have been provided by Mrs. Benson.
Your Honor, I have a... what can you... Let me show you what you presented last week, and it's a defendant exhibit quadruple V. Now, in this simulation, this was prepared by Dr. Malin Ornelas, is that correct?
Yes, it was.
And this is the top simulation here is what you indicated was representative of a 25 milligram dose administered by Dr. Murray at around 1040 or 1050, and a 25 milligram dose administered by Michael Jackson around 1140 or 1150. Is that accurate?
Yes, it is.
And were you, I know you indicated Dr. Ornelas is the one that created this, but were you working with her to create it? In other words, were you providing her data, information upon which she would base the simulation?
I did not provide her really any guidance whatsoever. She was watching the proceedings on television. I asked her about if she could help me calculate the amount of unchanged propofol in the urine in milligrams in these two different scenarios. And she came up with these graphic displays based on the two suggested possibilities, the one by the defense and the other by the prosecution.
And the lower model on defense quadruple V, that is what, in your testimony, in your opinion, documents the relevant urine levels of unchanged propofol. Is that accurate?
That's with two 25 milligram boluses, one given slowly, the other one given rapidly. Correct.
And the exhibit, the lower exhibit on quadruple V states it's based on Simons et al. 0.3% measurement. Is that referencing a particular article or manuscript?
I believe that's the manuscript that Dr. Mellon Ornelas used for estimating the amount of free propofol you would expect in the urine, and it was, I think, a radio-labeled study, so it should be very accurate. And I think she also looked at other papers that confirmed this number, but I think that was the primary reference that she used in the model. And as I understand it, the model was essentially the same model that Dr. Schaefer referred to, one by Schneider et al.
And the article upon which you based your testimony as far as the 0.3%, 0.3%, is that this article I have in my hand? Let me try on the screen briefly.
Yes, it is.
Okay, published in 1988. The first author there, Simons.
Correct.
And you felt that that was the most accurate accounting of unchanged propofol in the urine?
Actually, I didn't make that determination. Dr. Mellon Ornelas is the one who did the pharmacokinetic modeling. She's the one with expertise, not me. So she used what I think is, which appears to me, based on the fact that it was radio-labeled propofol, to be a very accurate way of estimating that. So I guess the answer is yes.
Did you read this article, Dr. White?
I did look over the article. I didn't really analyze it.
You came into court and testified regarding the unchanged propofol levels in the urine, told this jury your opinion. Did you read this article in detail upon which to base your opinion?
As I said, the pharmacokinetic analysis was done by an individual with expertise in the field.
Did you read the article, Dr. White?
I looked at the article. I didn't read it in detail, no.
Okay. And you started working, just to be clear, you started working with Dr. Ornelas. You first met her last week, right?
She was contacted by someone on the defense team as an expert in pharmacokinetics, and I had a conversation with her and met her last week, later in the week, Wednesday or Thursday.
How many hours did you put into collaborating with Dr. Ornelas to conduct your computer modeling that you've testified to this jury?
Firstly, excuse me, but I did not perform the computer modeling that you keep referring to. I don't know how many hours Dr. Ornelas spent working on this. I asked her a very simple question, not even to do modeling, just to give me an estimation of how much propofol you would expect in the urine if a patient got two 25 milligram boluses of propofol versus 1,000 milligrams, because the numbers that were provided at autopsy in terms of concentration of propofol, free propofol in the urine, did not seem to be consistent with a 1,000 milligram infusion given 3 hours before Mr. Jackson died. So
how many hours, I'm sorry, doctor, how many hours did you put into collaboration with Ms. Ornelas prior to your testifying, so you were competently informed as